Good morning, Peter Goertz. I'm a psychiatrist. Patients' lives behind their diagnoses. Do patients have lives behind their diagnoses? Of course, but sometimes that's ignored. I was talking with a patient this past week, and this issue really confronted me. He was talking about his childhood, just horrendous things, and I was thinking, how can anyone be, quote, normal after going through something like that in childhood? And I'm not just talking about direct physical or sexual abuse. People are given diagnoses like bipolar disorder, schizophrenia, major depressive disorder, but in general, diagnoses in the DSM don't address or even talk about things that happen in patients' lives. So things that may be behind those diagnoses. An exception is PTSD, where you have to have had trauma to meet the diagnostic criteria. So sometimes I think the diagnoses we give people, like bipolar disorder, may just be euphemisms for people who've been through terrible things in life. An example is a patient was telling me he was next to his father when his father killed people when he was a child. Another patient was in the house when his father killed himself. A common thing I hear is that people witness their father beating their mother regularly. Another patient was telling me that he had to do his homework outside in a neighborhood where there was regular shooting not far from him. Another patient was very fond of kittens growing up. And at one point, a family member killed the kittens in front of him with the intention of causing emotional pain for the patient. So just really terrible things that you hear as a psychiatrist from patients about what they experienced. And their biological aspects, psychological aspects, emotional aspects, social, spiritual aspects, but they all seem to be connected. And if someone's been through trauma, their brain can change, the physical brain can change. The way the DNA is read, so which parts of the DNA are read, which ones are not read can change. So epigenetic changes can happen. And epigenetic changes can be passed on to the next generation. For example, if someone's been through the Holocaust or went through the Holocaust, their children might inherit those same epigenetic changes in their DNA. So one way of looking at this is the biological and psychological may represent two aspects of the same coin, so two sides of the same coin. And in general, things don't seem to happen out of the clear blue sky. So we want to hear about patients' lives as psychiatrists. We want to be able to tolerate hearing about patients' lives. It's easy. These things are terrible to hear, not pleasant to hear. And for that reason, sometimes my sense is we as psychiatrists may have the inclination to not even ask about things like that. So not even ask about trauma during an emergency room interview, and sometimes it's not appropriate. And especially, if the patient doesn't want to talk about it, of course you don't want to get into it. But we don't want to ourselves, just because we don't feel comfortable hearing about trauma, we don't want to neglect asking about it. And when we ask about it and hear about it, we want to be able to tolerate hearing about it, which is not necessarily easy or pleasant. But doing all that can help us a lot, in my opinion, in understanding patients. And then that understanding actually can help quite a bit in prescribing well for the patients. Thank you.